Good afternoon. We're here in Barcelona, Spain for ESMO 2024, and I'm here with Dr. Jørgen Jensen from Aarhus University in Denmark. We're going to discuss the TOMBOLA trial, which will be presented during this conference. Welcome, Dr. Jensen.
Thank you very much.
Can you tell us a little bit about the design of the TOMBOLA trial and the planned outcomes and what you're looking for in the trial?
Yeah, so the trial is in bladder cancer patients undergoing cystectomy after neoadjuvant chemotherapy. And we decided to do it as a single-arm study instead of a randomized trial for several reasons. One of the reasons was that the study leading up to this was a trial where we took the exact same patients and just did observation on them and looked at the ctDNA level. So we used the patient's own tumor to design an assay for each patient and found out that in that trial, the patients where we could see positive ctDNA in the follow-up, all of them, they had a recurrence. So we discussed whether it was ethically correct to randomize these patients between observation, if we knew they were going to have a recurrence or not, and then decided to do a single-arm study. With the downsides of a single-arm study. But during the study, I think we found out it was a very good idea, because then it was introduced that we should give high-risk patients, or so-called high-risk patients, adjuvant immunotherapy. So we didn't have any ethical dilemma of continuing the study and not giving adjuvant immunotherapy to the high-risk patients as long as they were included in the study. So basically you could say that our high-risk patients during the study period, they avoided having this potentially harmful immunotherapy if they were, say, ctDNA negative. So a single-arm study, but intervention based on ctDNA positivity or not.
What were the time intervals that you checked ctDNA starting after cystectomy?
Well, we do it first. We do it every month, and then we skip to every second month. And we found out that the first measurement was a bit insecure because you have a lot of circulating DNA in the blood just after the major surgery. But very interestingly, the patients that have positive ctDNA, 75% of these have been identified within the first 4 months. So basically, we think that you can just do sequential measurement very early on and find the correct patients. And maybe we do not need to have as frequent intervals in the longer run.
And as soon as patients' ctDNA became positive, then they would start 1 year of adjuvant atezolizumab.
Yeah, exactly. Yeah, and you could say the studies behind adjuvant immunotherapy are based on high-risk patients. And what we could see in our own study was that the lead time between positive ctDNA until you could see something on the CT scan was very short in those patients. So you have a very short window to give this treatment, whereas in the low-risk patients, you have a very long lead time. So maybe those are the patients that benefit most from this. And you called it adjuvant. I don't know whether we should call it adjuvant because we actually treat a biochemical recurrence.
True. That's a good point.
It's more or less a treatment of metastatic disease, even though we do not know where the metastases are.
It's essentially micrometastatic disease.
Yeah, exactly.
Yes,
exactly.
Yes. So, obviously in Vigor 011, similar trial, they just finished accruing, so we will look forward to results to that. But as you know, the landscape is changing quite quickly, especially in the perioperative space. We will see Niagara results today. And then we saw some data from Volga today for our neoadjuvant clearance of ctDNA. So how do you contextualize your findings of your study in terms of the rapidly evolving perioperative space, and where are some other areas that we can potentially investigate ctDNA?
I think one of the very good things about our study is that we are not relying completely on a specific treatment. We have a way of measuring whether the patient still has disease left in the body. What we're exploring right now is whether we can make it even more sensitive. ctDNA is a funny thing. It measures metastatic disease, but it's not that good in the current setting to look at the local tumor. But hopefully we can find a way of also seeing whether the patient has remnant tumor in the bladder or not. Because we know from our national data that 49% or something like that has no tumor at the time of cystectomy. But we cannot foresee which patient these are. And if we also can use ctDNA for that, then we're moving into the bladder sparing thing. And even though you change your ways of treating before cystectomy, after cystectomy, whether we do cystectomy at all, I think we can use the ctDNA in a current form to see whether the patient should have additional treatment or not.
So more optimized approach, kind of like we're seeing with the modern trial and
Yeah.
other trials under investigation. And the patients that were ctDNA negative, how many went on to develop recurrence?
2 right now, as we can see them. So that's equal to 3%. And we have looked these patients up and so that they were actually low-risk patients. And it's so few patients, so we can't say a lot about them, obviously for anonymization reason. But you could speculate whether recurrence in the lung is an actual recurrence or a primary lung cancer.
We don't know. Okay. Were any findings from the study surprising to you?
Well, basically right now, I think what we're seeing as a percentage of patients that turn from ctDNA positive and change to negative during immunotherapy with not developing metastasis is very high. So that's quite a surprise that it's so high. But we're also realistic, so we know that it might not continue that way. They may develop a metastasis later on. We have just downsized the metastatic disease, but we'll be very interested in looking at that in the future. And then it's probably just a question of giving another treatment that's more effective than the current immunotherapy we've been giving in this study.
Are you at all investigating ctDNA in the metastatic or locally advanced setting?
Well, we have been doing that, and that's where our original data came from also. But right now we have we're mostly investigating in the potentially curable patients whether we should give this adjuvant therapy or not. And I think with all the upcoming drugs, they might be wonderful, but they also have side effects and they come with a cost. So if we can reduce the use of that to the right patients, so patients can avoid a potentially harmful, costful treatment if they do not need it, I think that's where the future is. Yeah,
I think with a lot of these perioperative trials that we're seeing is there may be a concern about overtreatment of some percentage of patients, and perhaps ctDNA, exploration into who can safely de-escalate may be a good avenue too.
Yeah, and you can say ctDNA is of course also a cost, and it's quite problematic to get the setup. But compared to a lot of these new treatments, it's definitely worth the cost to have the setup. And in this trial, we managed to have a setup of doing this analysis in all patients undergoing cystectomy in Denmark. So we had a national setup with all centers. We started up during COVID lockdown, so it is possible to do it.
Yes, very good. Well, thank you so much for joining us today.
Thank you.